The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety. This is the Flightbridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, welcome back. I wanted to take maybe 5 or 10 minutes and just do kind of a quick follow-up podcast. And so this podcast is going to be a follow-up to our podcast that we did on push dose pressors 6-8 months ago. If you remember, I did a podcast on push dose pressors and kind of looked at the different medications that we would use in that setting. Obviously, push dose pressors are something that we in the pre-hospital environment are, we're reading a lot about, we're hearing a lot about this from the MD level, the anesthesia level. But we have to remember that a lot of times that evidence, that research does not translate to the pre-hospital environment. So I think the jury is still out regarding push dose pressors. And I think based on the podcast, based on our following, and my conversations with different people in the industry, I think it's important for me to have the responsibility to have a follow-up podcast. I know that a lot of you out there take what we say, and I appreciate that and take what we say as golden. And I feel like we present the material, and I try to present the material in the most objective way. But I think we also have to remember, just like the disclaimer that I put in the beginning of every podcast, that we have to still maintain our good critical thinking, our good decision making, and go by our protocols, and that ultimately we're held to a standard based on our medical directors. And if those medical directors don't feel that push dose pressors are warranted at this time, then that's something we have to kind of consider. There's been a lot of cases that has been brought to my attention from people high up in the industry. I think, in a positive way, just kind of reinforcing things that they're seeing, that there's a lot of providers out there that are just trying to basically practice medicine. They're trying to, they'll just, use push dose pressors on patients based on not just RSI situations, not just patients that are in hemodynamic collapse in an airway situation where you need to push these medications, as we illustrated in that podcast. But any patient that has, hypotension, maybe it's a trauma patient with hypotension, or anybody with hypotension, and they want to try to boost that blood pressure. We have to remember that push dose pressors are used in the anesthesia world. And it was funny, I got into a conversation last night with Alan Wolf, my good friend and ultimately one of my high-level supervisors. And, I think, as I've said it before, he's somebody that really is objective, and he allows me the opportunity to critically think and to weigh in on, just different views on things, and he listens, and he vets those things, and we have good discussions. And I think that's great that each of us have that person in our life that, or multiple people in our life that allow that or stimulate those conversations. And we were talking about this, and he kind of made a funny statement, and he said, anesthesia is, they don't want their patients to decompensate or arrest in the OR. That they'll give push dose pressors in those patients to get them into the ICU. And, we need to always think that in the anesthesia world, that's a much different world than the pre-hospital world. And anesthesiologists are ultimately MDs. They're giving push dose pressors, and that's one of the things that they're an expert in. They're an expert in pharmacology. They're an expert in how different drugs work and interrelate with each other. They're an expert in gases. They're an expert in airway management and ventilation, and all those things kind of play into the decisions that they make to give push dose pressors. And ultimately, we're flight nurses, flight paramedics, nurse practitioners, PAs, things like that. There's flight physicians out there, obviously, that can make those decisions. But we're not able to do that. We shouldn't be doing that until there is current literature out there that backs using a push dose pressor. Now, one of the things I find that I respect is, for instance, Scott Weingart. Scott Weingart, as many of you know, is, I think, the guy that started the FOAMed movement. If you look back 7 or 8 years ago when he first started EMCrit, he, as far as I'm concerned, was kind of that pioneer. And, he has changed his stance on different medications through the years. And that stance is based on being objective and looking at the literature, looking at the numbers, looking at the science, and not forming an opinion based on, what we think we know, but looking at a study for what it is, and the study for the size of the sample that they use and the amount of things that go into that study. And I know he has changed his mindset on push-dose pressors as far as using neosynephrine over epinephrine. And I know if you listen to podcast, 4 years ago from him, he really liked neosynephrine. He liked to use it in neurogenic shock and different sepsis kind of algorithms. And he's gotten kind of away from that now because of some potential issues with the neosynephrine. And I think the same thing goes for push-dose pressors. I know he really preaches, if you are going to develop a protocol for push-dose pressors, if you are going to utilize push-dose pressors for you MDs out there, that epi is probably the way to go. And one of the things that we're finding based on, again, these conversations I'm having with people is repetitive doses or just single doses of neosynephrine can drastically cause reflex bradycardia. And if we're already having a patient that's decompensated, we know that heart rate is everything. Heart rate actually increases cardiac output. And if you're already looking at a patient with a decreased cardiac output that's hemodynamically unstable, and now you give them neosynephrine in the hopes to clamp them down, and it causes reflex bradycardia, you're going to be kind of counterproductive in that situation. So again, the best thing to go with, I think, based on all sources, is going to be that epinephrine. If you are going to develop a protocol, I know you can go on the EMCrit site. One of the things I remember from that is how to use an epinephrine push-dose pressor kind of mindset. And what the recommendation is that you're going to take a 10 mil syringe, so like a 10 mil flush. You're going to dispel 1 cc of that, and then you're going to take a cardiac amp of 1 to 10,000 epinephrine, and you're going to draw in 1 mil of that. And so you'll have a total of now 10 micrograms per mil of epinephrine in that 10 cc vial. So basically now you have 10 mics per mil. The dosing, again, based on if you're going to develop a protocol, is going to be anywhere from 0.5 to 2 mils every 2 to 5 minutes, which is about 5 to 20 mics at a time, based on, again, the concentration. So, epi is going to be kind of probably the medication that I would suspect, if there is ever a protocol developed for push-dose pressors, I think that's the one that's going to be utilized. I don't think neosynephrine is showing benefit. I think it's showing a lot of side effects. And again, for those of you out there considering this, or you've done this actually in a patient situation, remember, if there's no protocol for it, man, you are really, really stepping on a fine line there, and you really need to be careful. Remember all the hard work it's taken to get you to this point in your career, and doing something like that is not going to, be a good situation. And we also have to think about our patients and think about, despite giving a push-dose pressor based on their illness, their presentation, if it's a trauma, are they going to survive that anyway? And I don't think it's worth that. I think you need to always go off of your current guidelines or protocols. I think it's important to critically think. And we actually cause change by going the right routes, by showing literature, taking the literature to your medical directors, and going through the right channels and having a protocol implemented, rather than just arbitrarily practicing medicine and dealing with the consequences. I just think that can be kind of reckless. And I think for those of you out there that trust FlightBridge, that trust the things I'm saying, I think it's important that you share this with your friends, with your colleagues, and spread the word that I think push-dose pressors may someday have a place in pre-hospital medicine, may have a place for patients that are going to be RSI'd, that potentially are hemodynamically unstable. Does ketamine kind of take the place of that? Does ketamine optimize cardiac output to in enough of a way to constitute utilizing that instead? I don't know. But we need to look at this from the perspective of applying it to pre-hospital and not using anesthesia literature to guide our practice. So again, this was just a quick update on our push dose pressors podcast we did earlier in 2015. Please refer to that if you want to hear that again. And again, until next time, I appreciate everybody, and we'll talk to you soon.
This has been a production of the FlightBridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.